Shoulder has been a strong interest of mine. I would say that it's probably about 60 to 65% of my practice. You know, I do a lot of work with knee injuries as well, but this is sort of my interest in many respects. That I enjoy working with shoulder injuries because it is it's really the most fascinating joint in the body, I think, we are learning so much more every year in how to treat shoulder injuries. We've come a long way since my residency in treating all kinds of shoulder injuries. Today we're really going to talk about shoulder injuries in young people. That doesn't mean that I don't treat shoulder injuries in all people, but and I will answer really any questions about shoulder injuries in general. But tonight's topic is really about shoulder injuries in athletes, and for the most part we're talking about shoulder instability. About 95% of the shoulder injuries I treat in youth are because they're unstable shoulders, whereas most of the patients I treat who are middle-aged and older have usually too tight shoulders. So that being said, this talk is basically to review shoulder injuries in this age group. There's a lot of information I'm going to throw at you tonight. I really will move through this, but I want to say that there'll be plenty of time at the end for questions. And please, there's no question that is too ridiculous. I really mean that. So if you have a question later and it sounds simple or basic, please just ask it. I want to talk a little bit tonight about the current concepts in treating shoulder instability, what got us here, how we got here, and how we treat these compared to 20 years ago. Shoulder anatomy. I always like to start to talk a little bit about the shoulder. Shoulder is a ball and socket joint, and what makes it so fascinating is that the stability of the shoulder is inherently based on the soft tissues around the shoulder, not the bone, as compared to a hip. And I'll show you a picture of that. And if you look at this is a picture of the shoulder with the humeral head out. The rotator cuff is the outer layer, and the inner layer are the ligaments, the glenohumeral ligaments. I don't have a pointer, but you can see them. And the labrum, which gives the shoulder its depth, its socket, and gives the shoulder its stability. So when we look at shoulder anatomy, I think of the shoulder as in layers, to keep it simple. The outer layer are these big muscles that everyone sees on themselves, the deltoid, the trap, the pectoralis. And that is not, those muscles look great, but they really don't add a lot to shoulder stability. This next layer down is what we hear about all the time, the rotator cuff muscles. 4 muscles. They sit on the shoulder blade, they attach to the shoulder as tendons. And there's the subscapularis in the front, the supraspinatus on top, the infraspinatus and teres minor in the back. They are the sit muscles. They sit on the shoulder, and they are the ones that give the shoulder its stability. They help the next layer down, that purple group, that ligament area, which is the primary stabilizer of the shoulder. So the rotator cuff are the dynamic stabilizers, and they help this next layer, these inner layer ligaments, these capsular ligamentous stabilizers. And it's these ligaments that tear and cause the shoulder to dislocate or sublux. And we'll learn a little bit about what the difference is between those two concepts. The ligaments are divided into the superior ligaments, the middle glenohumeral ligament, the inferior glenohumeral ligament. They're bands of tissue at various parts of that glenoid that I showed you. and they give the shoulder its inherent stability. And those ligaments can tear when the shoulder dislocates. The labrum is this inner layer. So here's the ligaments, and then the inner layer is this labrum. And that's like the tire on the wheel, the rim. And that's what gives that, it's that tissue that attaches to the ligaments and provides that depth to the socket and the stability to the shoulder. The biceps tendon, we hear a lot about. It gets inflamed, it gets torn. As we get older, it rubs in this little groove and will tear. I get a lot of patients with biceps problems, and it's often hard to confuse them. It's easy to confuse them with rotator cuff problems because the rotator cuff is directly next to the biceps tendon. But the tendon can tear along this sheath as it rubs in this groove from overuse. And biceps tendon pathology is often missed. It's hard to see on an MRI, and it's frankly, we don't, and we're still not quite sure what the biceps tendon does in terms of stabilizing the shoulder. We know it helps the brachialis muscle give strength to the distal, to the elbow flexion, but in terms of its shoulder stability, it's still a little bit up in the air exactly what the biceps tendon does for the shoulder. We do know it can be very irritating though. Scapulothoracic anatomy, this is the anatomy in the back of the shoulder blade. Extremely prone to injury. It's very, you know, still we're quite unsure in terms of how these muscles affect the shoulder joint itself, but I get a lot of patients with trap strains and intrinsic muscle strains of the cervical musculature. They are linked to the shoulder in terms of motion and stability. Then when we're talking about, and those muscles that we're talking about are the trapezius, the levator scapula, the serrati, and the rhomboids. And this picture I like because it goes over that basic concept of shoulder stability compared to the hip. The hip is a ball and socket, and the stability is provided by the joint itself. The ball in the socket. It takes a lot of force to dislocate that the hip. Hip dislocations are really quite rare. They're usually from major trauma. Shoulder instability, the ball is round like the ball in the femur, but the socket is just a little saucer. So it's the soft tissue anatomy that gives the shoulder its stability. And it's not the bony anatomy. So that's why and the reason why the shoulder socket is so shallow is because we have much more motion in our shoulders than our hips. So we need that to be functional. And in order to have that function, there's a dynamic equilibrium between the muscles and ligaments to give you that mobility and still have stability. So the shoulder still stays in place. It's it's fascinating. And when we look at the injuries, we have to look at the athlete. I mean, each of these athletes, I use these two as an example because this swimmer, she has shoulder instability, and so does this football player, but the injuries are totally different. Hers is based on overuse, hyperflexibility, and this is more of a traumatic injury. So when we look at injuries, we look at to see if they're traumatic, like the football player, or atraumatic, like the swimmer, whether the shoulder dislocates, meaning it literally comes out of the socket, or whether it subluxes, which is very common, and that means where the shoulder actually slips out of the socket, slips back in, slips out, slips back in. I see that often, and that is very common in swimmers and other gymnasts and so forth. And then we look at to see where did the shoulder come out? Did it come out the front, anterior? Did it come out the back? Or did it come out both? We have that patient, that athlete, where the shoulder comes out front, back, up, and inferiorly as well. So that's the way I classify instability of the shoulder. And again, here, this picture has an instability problem, and his shoulder problem is very different from that wrestler who's in the process of dislocating his shoulder traumatically. Multidirectional instability, I talked a little bit about. That is very difficult to treat. These patients have instability in more than one plane. Front, usually it's anterior, posterior, and slightly inferior. And the pathology is extremely multifactorial. It's a combination of muscular instability, the ligaments, that capsule that I showed you is lax. And the treatment is very often a non-operative rehab program. This is a patient with multidirectional. You can see she's smiling. That's not a good sign. That means that she has a minor shoulder popping out. She usually is hyperlax, like that finger exam shows. And these patients are very, very difficult, these multidirectional instability patients. And on MRI, you'll see that the capsule is, this is a normal MRI, pretty much. You can see the capsule, the fluid in the shoulder. This is the ball and socket. We'll go over MRI a little bit more, but this is in a multidirectional. You'll see the fluid is not that bad in a multidirectional patient. I mean, in a regular MRI, normal MRI, but in a multidirectional, you can see the fluid, and that means that this shoulder is just so loose, the ball and socket is just popping in and out. Oh, sorry. So let's talk a little bit about non-operative care. There is a place for non-operative care in shoulder instability. Many patients, not everyone needs surgery. And that's really a combination, that decision's made by your orthopedist. Now, for first-time dislocators who are middle-aged, I'm treating them in a sling for a short period of time followed by a rehab program. And I really think a lot of them don't dislocate again and have a very good result. But the truth is, for my college-age kids and younger, once they dislocate, there's a 90% chance that they're going to dislocate again. 90%. Just because of their activity and the anatomy that the trauma to their shoulder that's occurred. So I'm immobilizing my athletes for a couple of weeks and then starting them in rehab. But for most of the athletes that are younger, I'm studying them a little more closely with imaging, MRI imaging. Bracing. This is back to non-operative care. For some of my patients who dislocate their shoulders, I will use a brace for a short period of time. But that group is really what I'm doing with them is I'm buying time for my young athletes because eventually they're going to need some type of surgery to stabilize their shoulder. Most adults, I don't use braces because usually their shoulders are strong enough and they don't pop out, they don't dislocate again. But for my football players who are trying to get through a season, we will use a brace. And what that does is it protects the shoulder so it doesn't go through, get into that position where it's going to slide out. Very, very effective for football. I mean, we've used it for football. Very nearly impossible for basketball and volleyball. But I'd say most commonly I use this brace in football players. Rehab. I'm not a physical therapist, but I really have an interest in it. I think that instability, if you're going to do a rehabilitation for your unstable shoulder patients, I don't care what age, you really need to have a good rapport with the physical therapists. Whether it's a therapist or an athletic trainer, you should be talking to them about what's the instability? Is it multidirectional? Is the shoulder unstable in the front, acute? Is it anterior? Is it posterior? Was it a once and done? In other words, was it one dislocation or are they having subluxations, multiple episodes of instability? So I really think that you need to, if you're going to rehab them, you need to communicate with your therapist. Sorry. And what does therapy involve? Really strengthening, not a lot of stretching, because frankly, the stretching's been done by the injury. So the rehab is working on those dynamic stabilizers, the rotator cuff, the levator scapula, the rhomboids, the serrati, and it's working in specific, lightweight, high repetition exercises. Stabilizing the scapula, stabilizing, rotator cuff strengthening. And again, you got to communicate with your therapist. There's other things I do in rehab. I use neuromuscular control, proprioceptive strengthening, again, eccentric strengthening. These are all ways of stabilizing the shoulder in hopes of preventing it from having another instability episode. Now, this is how we originally treated shoulder dislocations back 400 BC, and sometimes I think the initial treatment hasn't changed a whole lot, but this is the same injury a couple years ago, and that is an anterior shoulder dislocation. This is what, when we think of shoulder dislocations, this is what we, what most people consider a primary lesion. So it's a acute traumatic dislocation out the front. That's the most common shoulder dislocation anteriorly. And it's a anteriorly directed force to the back of the shoulder when the arm is turned out, abducted and externally rotated. And that's a good picture. You can actually see, this is a good shot because you can see her shoulder is dislocated anteriorly. The ball is in the front. This is the normal shoulder, normal contour. Here it's squared off. So you know that that shoulder is dislocated, clearly different. And this is a picture of what's happening. When that force occurs, as you see over here, the shoulder is slipping out the front, and these ligaments are torn. This labrum often tears with it. That's the labrum we talked about with the normal in the normal anatomy section. How do we reduce them? Sometimes the most common way is the way you saw Hippocrates do it in 400 BC, and really what we're doing is, if we can get to them early enough, and we can get them as early as minutes on the football field sometimes, we'll put a little resistance, a little towel under the arm and do it in traction longitudinally. And if the muscles aren't in cerebral spasm, the shoulder can reduce. You don't fix the injury, but you certainly get the shoulder back in the socket, reduce the humeral head. If you're uncomfortable with traction and you're all alone, you don't have a doctor, you can also put them prone, put a little weight on them, and just let them hang. And that shoulder will relax enough and reduce often. I had a physical therapist do this maneuver a couple years ago up in our East Stroudsburg office, and the shoulder reduced very nicely without any other traction or pulling. This is what I always, once you have an injury like a shoulder dislocation, you need to get an x-ray. Why? You want to make sure you don't have a fracture. You want to make sure the shoulder still is back in the socket. So, because a shoulder that's out of the socket for a long period of time, that's been dislocated, and is a almost impossible problem. Once it's out for like a day or two, it's the blood supply to the shoulder has been compromised, and it's a serious problem. Shoulder dislocations anteriorly are often never missed, but posterior dislocations are often missed because they're more subtle. The patient just has pain. The shoulder isn't quite as visibly dislocated, and it's one of the most missed orthopedic problems, and it is very problematic if the shoulder's been out. I've had a shoulder patient come in posteriorly dislocated for 3 weeks. So I get an x-ray. And x-rays have to be 2 views. I know this is a little technical, but it just makes sense. You want to look at it this way, and then looking up into the armpit. That's called the axillary view, and that second view, that axillary view, confirms the dislocation. Confirms the position of the shoulder, that it's where it's either in or out. MRI. Now, does every shoulder dislocation need an MRI? Absolutely not. But I've gotten a little more quick to order that in my young athletes, and I'll tell you why. Because 90% of the time I'm going to see a tear like this or a tear like this. And what is that? That's called a Bankart lesion. That's a tear of the labrum off of the bone itself, off of the glenoid. And if I see that tear, I know most of the time that will not heal by itself, and that athlete's going to have chronic instability. Now, this MRI has a little, if I'm going to get an MRI in an athlete, I'm going to put a little dye in it. It's called an arthrogram. And that's to give, so I can see the actual detail of the labrum. Because if you get just a regular MRI without putting a little dye in, you will not see that lesion. So if we're going to get the MRI today, I get an MRI arthrogram. So my current recommendations are to treat surgically all patients under 30 with that Bankart lesion. So if I see that Bankart lesion, like I showed you on that last slide, that patient, I really do recommend early repair. Because number one, I'm doing them arthroscopically. I'm not making open incisions anymore, so I know that I can stabilize that shoulder without creating a lot of scar tissue and going through a normal muscle. So whereas years ago, I would let that shoulder dislocate a couple times, and I think I'm doing it, but now I'm preventing, I think that by letting them go on to chronic instability, they have less of a chance of having a really good result than if I can fix the first-time dislocators. And that's changed a lot. I mean, I've changed over the last 20 years. I am treating the first-time dislocator, the under 30 first-time dislocator, much more aggressively than I did in the 90s. Again, over 30, I'm treating that guy a little more conservatively. I'm rehabbing him, watching him a little more closely. And, you know, I would say before 2002 or 3, I probably treated 95% of my patients with an open procedure. Now I'm doing 95 or 100, almost 100% of my patients arthroscopically. And I think that that's helped. I'm not making that big incision. I'm doing it through 3 or 4 little tiny portals. I do open repairs of the shoulder for some of my athletes. And I really like, especially some of my wrestlers, more so than even my football players. The wrestlers are probably the ones that are most difficult and are going to tear through my arthroscopic repair, more likely to. Whereas, you know, they're the hardest on shoulders. They're just doing things out on the mat that are not physiologically, you know, sane. And so, you know, if I've had any redos, revisions, it's been in my wrestlers. And we have a huge wrestling population here, so, you know, I get tested every year. So what's an open, this is how we used to fix them, and I do probably 2 or 3 a year of these open capsular shifts. This is the gold standard for many years, the open procedure where you actually make the incision in the armpit, you divide the subscapularis muscle, repair the ligament with an open incision, and then close the skin. And it really does work, and it even works in wrestlers. And that's kind of what this is called, a capsular shift. This is really, I probably did about 300 or 400 of these before I, you know, switched to my arthroscopic procedures. But this is what a capsular shift looks like. It is probably the most common procedure done in between 1985 and 2005. And then we repair the ligament, the Bankart ligament, with these anchors. And now we're doing this arthroscopically. So we're putting these little anchors into the bone, and then we're using them to attach the labrum back to the bone. And those have been around since about 1990, maybe a little bit earlier, but 1990 is when they took off. And we started to use a lot of metal anchors, and then which are this group here. And then we found that the bioabsorbable anchors were just as good, and the patient didn't have metal in the shoulder, and we felt that was definitely an improvement. And it's this generation of anchors on the right that we also use for our rotator cuff repairs. So I don't use any metal in the shoulder anymore. Those anchors, there are a few of my partners that do use some metal, but frankly, I've gone to all bioabsorbable anchors. My patients like it. They like the fact that they don't have metal, whether it's for labral repair or for rotator cuff repair. That's what the open incision looks like. You can see the repair on the left and the labral repair capsular shift, and that's the incision. Again, it's not a huge part of my armamentarium. I do get some guys who are in their 30s and 40s now who had really bad instability. They have fractures of the glenoid that never healed, and they have these huge defects in the bone. Those are called Hill-Sachs lesions. And for that group, we actually do a bony procedure where we move the bone, a piece of the coracoid, in front of the glenoid and attach it. And that's a real salvage procedure, I call it. Very rare. I do about one a year, maybe two. And it's called a ladder J procedure. And you can kind of see how the bone moves. And we use this bone, this part of the coracoid muscle. This is where the coracoid lies in the front of the shoulder. These are the teres minor and the biceps tendon. They're called the conjoint tendon. And we actually take this piece of bone, attach it to the front of the glenoid, and it gives you a bony buttress and repairs that. It works very, very well. And it's a salvage procedure. It's for the patient who has had a failed dislocation in the past, failed surgical repair, either arthroscopically or an open capsular shift procedure. Now, this is the mainstay of my practice. Really, I do 90% of my work now arthroscopically. The only time I really make an incision is to do a shoulder replacement or to fix a fracture, pretty much. And this is how I set up my shoulder. My patient's in a beach chair, in a lateral decubitus position, their shoulders suspended. I use 3 little holes, or 4, sometimes the second one here for my shoulder. This is the top of the shoulder. Here's the arm, it's suspended, and patient's on his side, and it gives me excellent access to the shoulder. I can see the shoulder better than I can open, to be honest with you. This is what a arthroscopic Bankart reconstruction looks like. We can see the shoulder right through the scope. We prepare the shoulder with a little burr. We put an implant in, and then put these implants are attached to sutures. We tie the sutures to the labrum and then bring the labrum back to the bone. So here's the preparation part. Here's a little burr, preparing the bone. And then we make a hole, put an implant in. You can kind of see the shadow. And then that implant's attached to sutures, and here are the sutures, implant, reattach it. It works very, very well. And I actually think that I come from the school that did open procedures only for this, and now I feel that my shoulders are as stable arthroscopically as when I did them open. And that's saying a lot. And this is what it looks like. This is the front of the shoulder. These are these little portals. We bring these little plastic cannulas in. We work through them with these instruments. It's certainly a learning curve, but once you get it down, it's not that. I mean, really, you get through it, and it's not hard. What we're doing is we're restoring the labrum back to the glenoid. And I liken it to creating a bumper, like you're putting a bumper back on the wheel. So here's the bumper. You want to make this as thick as possible because this is what's giving you the stability so the shoulder does not dislocate. So here we are. You get down. This is like the bottom of the shoulder. Here's the top. The biceps tendons here. Here are that capsule. And here is the labral repair. This is really a good example of how we're doing it. The one new thing we're doing that's not in this particular presentation is, if you look closely, these are little knots, and we've always worried that those knots could create a little bit of irritation to the shoulder, and now we've gone knotless. So these sutures actually go into the implant without having to make a knot, and that we've been doing for about a year and a half, and has made that, and I think that's even made it more fortunate, just better surgery, better technique. This just is a technical pearl, but I gave this talk to a group of orthopedic surgeons, but you can see that when we repair the labrum, you want that bumper up as high as you can, and you can see the bumper we're creating. And you don't want it out here because the shoulder is still unstable, doesn't have that nice big rim of tissue that we saw in that last picture. That's just a picture of a labral tear. There's some video here, but I think it's just a little bit beyond us right here on this talk. But here's slap tears. Slap tears are, again, labral tears, but a little bit different. The slap tear is a tear that involves the biceps tendon, and that tear is at the top of the glenoid. They can occur two ways. They can occur from sliding into a home plate or a violent outstretched injury or repetitive motion. And, you know, I see a lot of people with slap tears. I think that the ones, I tend to treat these aggressively in my patients under 45. I hate to, you know, I'm over 45, so, but I can say that. But usually this type of tear in a 55-year-old guy is probably not really the reason why he's seeing me. He's usually seeing me for a rotator cuff problem. But I will tell you that I get MRIs on, you know, guys in their 50s, and many of them have that type of tear. But this tear is significant, this tear and this tear and this tear in my throwing population. So I grade these tears, and you can see the different types. This tear involves a little bit, there's a more full thickness tear. This involves the biceps tendon. This involves the biceps tendon, but goes all the way up into the tendon. That's a significant injury. And so these are different than the regular, those Bankart lesions that I was showing you on the previous pictures. And I repair these. I mean, this is how I evaluate the tear. We have a certain exam, but really you can see the tear on MRI. And this is the dye in the shoulder. You can see where it tracks. That's a slap tear. Let's see here. There's a good picture of a slap tear. You can see this whole group of tissue here should be attached here. That's a very unstable shoulder. That's a slap repair, okay? Again, arthroscopically. This is a tear that can't be fixed through open surgery, cannot. There's no way you can even see that part of the shoulder, and you'd have to, it'd be impossible. So I'm sure that people have, you know, gone forever without these fixed, or I think people did open procedures and never even saw the tears. This is the repair. You can see the anchors going in, the repair being made. But if you'll notice, these are pretty big knots, you know, and we've gotten rid of those. So, you know, I always worried about those knots, because here's the humeral head. This is the ball. And you know it's going to be rubbing on that knot a little bit. Now, those sutures do get covered in some fibrous tissue, but I think we've come a long way going knotless on that. And that's just another video of a slap repair. This shows you sometimes you can have a combined Bankart and slap tear, where the tear is in the biceps and down at the level of the labrum. Posterior shoulder instability, again, often missed. I can't tell you how many. I've seen at least 4 posterior dislocations in my office or in the emergency room, because this is a posterior dislocation, and if to the casual observer it looks like it's a normal shoulder x-ray, but really that shoulder's out. That shoulder is dislocated posteriorly. It's very, in the athletic population, I see it in linebackers. Very common. More so than anyone else. Posterior shoulder subluxation is more common than dislocation. So what is a subluxation? It's where the shoulder slips out and pops back in. See that in lots of athletes. That's an MRI of a dislocated shoulder. This is actually the CAT scan, and this is the MRI. You can see that this is lodged out. The shoulder is out of the socket. That's a tough injury when it's out that long. MRI is very helpful to separate shoulder dislocation. I think it gives you an idea of how much injury you have. So like in here, you just have a labral tear, but the capsule's still pretty intact. Whereas here, look at the capsule. It's all attenuated. It's out, stretched out. So this patient has not only a torn labrum, but he's unstable posteriorly. He has very lax capsule. That's a more serious injury on the right. So treatment, again, I repair the labrum, and if I have to repair the capsule or tighten the capsule arthroscopically, I will. I used to do these more, just like anterior shoulder instability, posterior I used to treat also open, and now I do pretty much 95 to 100% of those arthroscopically. And that's a picture of a posterior labral repair on the right. And that's another picture of a posterior labral repair. That's actually my patient. You can see this bumper we talk about. So there's the sutures. Here's the cannula. I'm tying the knot. And you can see this bumper. There's the socket, and we've restored the labrum. Multidirectional instability, I really want to emphasize that it's 90% non-operative. I've fallen into those traps of treating this patient surgically and regretted it. I do treat these with therapy, and I always worry about a patient who smiles when her shoulder is dislocated. Thermal shrinkage. I used thermal shrinkage. That's what this is. No one may not even have ever heard of this, but we used to use a heat probe to shrink the capsule, and I thought it was, I probably did about 15 or 20 in the mid to late 90s. It sounded great because you basically don't have to tie knots. You don't have to really treat the injury except to shrink the ligaments. But what we were really doing was, we were destabilizing it. We were making the, I think we were doing more harm than good. It was creating like thermal necrosis to the tissue. So that fell out of favor, and we really do not use that. I think there may be some people, but really it's the tool of the devil. And I've given up that. There were many debates in orthopedic literature, and then finally that just went by the wayside. And that's it. I threw a lot at you. I really, a lot of this stuff may not make sense, but I think this gives you a good concept of what shoulder instability is and how I treat it.
About 10 years ago, he had to go do the arthroscope, but he had to take it out and cut it because I now have 2 screws still in my shoulder. At the time he said, but it bothers you now. Should the screws ever come out?
Okay, I'm going to tell you what I think happened to you 10 years ago, okay? I think you probably had a rotator cuff tear 10 years ago, okay? And he put 2 screws in that are metal screws.
It was torn so bad.
Yeah. That you probably had did he make an incision to put the screws in?
He did arthroscope first.
And then
it was too bad torn, so he had to cut.
And he did that all at the same time?
Yes.
So it was one procedure. Okay. And then those screws probably aren't the cause of your pain, just so you know. No.
I thought maybe they came loose.
Well, you definitely, if you're having shoulder pain, you should have that looked at. Often, there's when I see a patient like you at this point in time, the most common reason for your pain is either a re-tear of your rotator cuff, okay?
Repetitions, because my job would require
or maybe like a bone spur where you're pinching, that shoulder's pinching. So like this isn't really the topic of this, but I'm going to say that when I see second opinions 10 years out, which I do all the time, the most common reason for their shoulder pain is either a re-tear of the rotator cuff or a spur that never was taken out 10 years ago. That's probably the 2 most common reasons. Go ahead.
What's the different purposes of the slings when you wear some people I seen when I tore my rotator cuff, I had the one that kept me flat, and some have I called it the Cadillac sling. They had that big pillow in there.
Now, when for rotator cuff surgery, the pillow is nice because it keeps the arm away a little bit, and there's some thought process that the blood supply to the rotator cuff improves with your shoulder slightly abducted. So when I do rotator cuff surgery, even if it's just a small tear, I use that pillow for 2 or 3 weeks, and for my bigger tears for anywhere from 5, 6, 7, 8 weeks, the abducted pillow to improve the blood supply to the shoulder a little bit. For my patients who I do just bone spur work like decompressions, I'm putting them in that little sling and letting them get their motion early.
Is that more of a surgeon's preference on what sling you use?
Yes, definitely.
I saw a couple of different people with similar surgery I had. They all had that pillow and it looked more comfortable. And to tell you the truth, like some nights I put a pillow, my own pillow under it and it felt better. But my surgeon, he didn't seem to.
I like the pillow for anything I'm repairing. Okay, anything because I think, and then the nice thing about the pillow is it's just a piece of Velcro. It peels right off.
Right.
Some of my patients, I always tell them after 4 weeks if you want to just go with a regular sling or use the pillow. And some people just use the pillow. Yeah, I'll tell them. Yeah.
Can you describe the procedure? You know, if someone comes to you for a shoulder, you know, examination, X-rays, the whole, kind of lay that out.
So when you come to see me, there's two groups of people: the people that are just, you know, that have a history, and the people that I have a shoulder pain for the first time. And those, you know, I group them a little separately. So my first time people, I get a set of X-rays and examine them. And if they've had, for my patients who've had shoulder pain, this is not my instability group, this is my rotator cuff group, which I've got a lot of people here with that. But that group, I'm going to, like if they've had shoulder pain for over a month, I'm going to probably look at that rotator cuff with an MRI. If they haven't had shoulder pain, if it's a quick injury like a workers' comp injury where they just strained their shoulder a week ago, I'm more likely to not treat that. I'll treat that with a physical therapy plan. But for my long-time pain, guys who've had shoulder pain for like, a lot of guys come in with shoulder pain for, you know, 6, 8, 9 months. That's telling me something. There's something, you got to evaluate the shoulder a little more properly than just, the X-rays help me a lot. I can see bone spurs, I can see joint space, I can see narrowing, I can see a lot on an X-ray. I use X-rays, and often the X-rays I get in my office are different than the ones that Muhlenberg and St. Luke's get, and Lehigh Valley. So I'm really careful. I mean, they usually get X-rays that are of no real value to me, to be honest with you. The ones they get in, like, that the family doctor orders, to be honest with you. So that's why, like, I really tell my, you know, my patients say, well, I already had an X-ray. Well, I have to get an X-ray often that's different so I can evaluate it the way, like a person who's a specialist should evaluate it. And then if you don't have a tear, okay, so let's say you get an MRI, and you come in with an MRI, and you've never been, but you don't have a tear, but you have shoulder pain. Well, that guy, I'm going to generally rehab him. Sometimes I'll use a steroid, but I often rehab you. And lots of those people get better by just getting their motion back and getting their strength back. And I treat them conservatively. But if you have a full thickness rotator cuff tear, I'm going to treat that surgically. Arthroscopically, but surgically. And if you, just like I would treat that Moravian college kid with a labral tear surgically. Because I know he's not going to get better unless I treat it. Because he'll be back. Or he'll be back 5 years from now, but his shoulder will be more unstable. And he'll ask me why I didn't fix him. It's that simple. So I avoid that. I used to avoid, like I was more conservative when I was doing open procedures, to be honest with you, but now I'm more aggressive to fix that lesion before it becomes worse. Just like ACL, you all have heard of the ACL, right? Well, we treat labral tears now kind of like ACL injuries. Like, we hop on them. Now, rotator cuff tears are different, you know? I mean, some people have little tears and they don't want to be treated, but if you have a small, full thickness rotator cuff tear, it's never going to get smaller. It's not going to heal. Partial tears, little tiny tears, maybe. But if you have a full thickness rotator cuff tear, I don't care if it's just the size of my thumbnail, it's never going to get smaller. It's always going to get bigger. I've had patients that have come to me and said, I don't really want to get it fixed. And then they come back 5 years later, I repeat the MRI, and it's not only bigger, it's almost irreparable. So that group, you know, I just tell my patients and let them decide. I really want them to know what I recommend. Arthritis is different. When you come in with shoulder arthritis, I mean, it's your decision. I had a patient yesterday, he needs a shoulder replacement, but he's going to think about it. He said, he should think about it. I said, go golf this summer, come back and see me in the fall. But that's different. You know, rotator cuff, you know, that I have to give him the guidance that's appropriate for the injury. He has arthritis. I mean, it may get worse, but I can still fix him a year from now. It's different than a rotator cuff. Anything, you know, so I'm treating this population, these guys back here, a little differently than like my 50-year-olds, and I'm treating them a little different than my 80-year-olds. 80-year-old comes in a rotator cuff tear, I'm treating her with a cortisone shot and some physical therapy, you know? And if she's got to beg me to fix her, you know? Now, do I fix 80-year-olds? I do. Oh my gosh, I can tell you, they heal great, but they got to really tell me they need it, you know? And so everyone's a little different. Everyone's a little different. Just, go ahead.
How long is the recovery on arthroscopic?
Well,
Is it?
It's not, the actual tendon heals to the bone the same way hers did 10 years ago. I do try, I've been doing something experimentally with this rotator cuff surgery that nobody else, I think maybe one other doctor does in my practice, and that is I'm taking a little blood from your arm, and I'm spinning it down right when I do the scope part, and I'm putting it into the repair. It's called platelet-rich plasma. You may have heard about it. It is a little experimental, but it's doing no harm to you, and I think this is one of my research studies right now. I'm looking at this, but if anything speeds the healing, it's that. I think it might. I'm not sure, but I know it's not hurting the repair. So I'm putting those little platelets right into the repair. And again, the data is mixed on it. There's other doctors in the country and in the world, for that matter, using it with, we'll say, different mixed results. But I know it's not doing anything bad. It's your blood, you know, and I'm doing that. But the actual tendon heals to the bone in 4 months. So the speed, the recovery is based on, do you have a full tear, or do you just have like a partial tear and impingement and bone spurs? For the patients with full tears, they're going to be, then it depends on how small the tear is, how large the tear is. Large tears can take as much as 6-8 months to heal. Small tears can be pretty much healed in 2 or 3 months. And that doesn't mean you're in therapy for that long. It just means that you need, that the tendon is going to need time. Shoulders take time to heal. It doesn't mean that you're not doing stuff. It just means that you're still getting better. You know what I mean? Does that make sense? It doesn't mean like you're not like out going about your normal activities, but your shoulder's still improving. They're not, we heal a little slower than that Moravian College group.
About driving.
Driving, oh my gosh, I let people drive within a week, even my big tears. Really? Yeah, I'd let them like loosen the sling up. I mean, I would do it. I mean, I don't think it's doing any of them harm.
The knee replacement drove stick shift for 3 weeks.
That's pretty awesome.
Okay.
Then you would heal great.
Where do you do your surgery?
Right there, across the street. I do.
Okay.
Yeah, I've been doing it there since 1998. I figure they know me pretty well.
And are your patients totally anesthetized?
Good question. I use blocks, okay, scalene blocks, and then light general. So like the only time I use just like awake patient is like really, really sick patients who can't take a light general. And when I put when I mean by light general, it's like, you know, you have a little arrow of airway, light general, you don't know you're there, you're out, but your arm's asleep. When you wake up, your arm's still asleep. It's asleep for about 6 or 8 hours. It feels like dead. You remember that, right?
Yeah.
And these guys over here do that block great, in Allentown too.
Yes.
But when you get into these other hospitals, I don't want to badmouth, but they don't do that block quite like these anesthesiologists. Like the folks, they just don't do them as often. I mean, they're doing them like, you know, 6-8 a day. So you want that block, you want people to do that often, just like you want your shoulder surgeon to do a lot of shoulders. you don't want your shoulder surgeon doing neck surgery and bunions. And that's the way we are today. Like really, I don't do that stuff anymore. I pretty much knee and shoulder, a little bit, you know, some joint replacement and the fractures that I have to treat. But I don't really, the days are gone when you're doing everything. I mean, there was a moment in my life when I did everything orthopedically, but it's not that way anymore. We've become a little specialized. Come on, Kristen, you must have a question.
What is some of the reasons behind not surgically repairing multi-directional instability?
Great question. Multi-directional instability is where that shoulder is so sloppy. okay? And really, when I stick that MRI in and do that MRI test, you don't see like a torn labrum. You don't see like a true lesion like you do with that football player that's dislocated and torn his labrum. Most multidirectional patients, they're just loose jointed. The capsule is loose. So in your mind, you'd think, well, just stitch the capsule, go around the, you know, and yeah, we've tried that, but generally they stretch them out again. And there isn't a really, like, we've tried that capsular shift procedure that I showed you, the open one, and that's like the last ditch effort. Have I ever operated on a multidirectional? Absolutely. I mean, but it's just not, you really, those people have had 1 or 2 years of physical therapy and even some psychological testing before I'm doing that surgery. Okay? I mean that really I do. I avoid multidirectional surgery. But rehab works for them most of the time. That's where you come in. Strengthening, right? You've seen the multidirectional patient, right? Yeah, I'm sure you have. We have had a couple this year. Swimmers. Swimmers and ballerinas and dancers and...
It's not really like a traumatic...
No, it's not traumatic.
Repetitive overuse.
Right. It's repetitive overuse. It's what it is. It's like the swimmers are classic. Absolutely classic. I mean, multidirectional. Most of those people, though, are straight up. They just want to get better. Their shoulders are a little loose. You know, there's a couple other people, though, that... I have one lady that claims she dislocated her shoulder 1,000 times. Anything else? Anything at all? Well, you've been a great... Yeah, go ahead.
I got one more question. With a full rotator cuff tear, can I get back to 100% of my range of motion?
Good question. You know, the question is, can you be like you were 18 years old? Probably not. Yeah. But
I'm only 17.
But you can be more functional. Like I always tell my rotator cuff patients, you can be a whole lot better than before you tore it. Because what happens is we put you in rehab and then you become aware of your shoulder and you start to do those exercises and strengthen it. And I think that you can be, you know, you can, depending on the tear though, you can be 90%, 100% of what you should be at your age. Okay?